Good day, friends and colleagues. So the PSVM, or the Philippine Society of Vascular Medicine, is very much into vascular diseases. So when you say vascular diseases, we talk about diseases of the arteries, veins, and lymphatics. Lympha what? Because when we search for diseases of the vascular system, most of what we see will be about arteries and diseases, venous diseases. But a lot of us are not aware about diseases of the lymphatic system. So for World Lymphedema Day, our Council on Lymphology, headed by Dr. Angie Anacleto, prepared something for us to learn from, so we can enjoy the discussion, and I'm sure we see a lot of this in our patients. So hope that you will enjoy this activity, and we'd like to thank our sponsor for this activity, Servier Philippines, QCMP Incorporated, and Zafar Philippines. And thank you to the members of the Lymphology Council for this very interesting activity.
Good morning, colleagues, ladies and gentlemen. Once again, the Philippine Society of Vascular Medicine has organized this activity to celebrate World Lymphedema Day. The history of lymphedema awareness in the Philippines dates back in 2013, when a group of vascular specialists decided to explore about lymphology by attending foreign conventions and certification courses abroad. Shortly thereafter, an oncology nurse, Mr. Jason Rojas, also took his certification course in the US to learn about complete decongestive therapy, which is the standard of care in managing these patients. Then in 2015, we had the privilege of organizing a lymphedema summit at the St. Luke's Global City with our invited guest, Dr. Stanley Raxon, who is the head of the Vascular and Lymphedema Center at the Stanford University Hospital. Finally, in 2016, a group of vascular specialists from Philippine Heart Center, headed by Dr. Teresa Abola and Dr. Melissa Bernardo, invited a lymphedema expert from the US, Dr. Andrea Brennan, to conduct lymphedema certification course in our country. Since then, lymphology became an integral part of our fellowship training in vascular medicine. I am truly honored to be part of the Council of Lymphology of the Philippine Society of Vascular Medicine, headed by Dr. Angie Anacleto, whose primary mission is to create awareness regarding this common yet under-recognized condition. Please watch this very informative video to celebrate World Lymphedema Day. Thank you.
So, good morning everyone, and thank you for joining us as we celebrate World Lymphedema Day. Today, we have prepared two interesting cases for you to learn about lymphedema of the upper and lower extremities. So let us begin the discussion. So in this morning's discussion of implementing evidence into clinical practice, we will be joined by several specialists. First, we have Dr. Jasmine Melissa Bernardo. She is the head of the Vascular and Lymphedema Center of the Makati Medical Center. She is likewise the head of Vein Diseases Unit of the Philippine Heart Center. She practices internal medicine, cardiology, vascular medicine, and she is also a lymphedema therapist and a capillaroscopist. She is currently the Vice President of the Philippine Society of Vascular Medicine. Next, we have Dr. Daphne Isa Lee. She is an active consultant of the Section of Medical Oncology of the Cardinal Santos Medical Center and the Medical City Ortigas. She is the research coordinator of the Section of Medical Oncology of the Medical City Ortigas. She is a member of the training committee of the Internal Medicine Program of the Medical City Ortigas. Next, we have Dr. Rafael Azares. He is an active consultant of the Division of Surgical Oncology of St. Luke's Medical Center, Quezon City, and UERM. He is a training officer of the Division of Surgical Oncology at St. Luke's Medical Center, Quezon City. He is also the training officer of general surgery at the UERM. He is also an assistant professor at the UERM. Next, we have Dr. John Mark Carabeo, who is an active consultant of the Section of Radiation Oncology at the Cardinal Santos Medical Center and Manila Doctors Hospital. He is currently the director of the Brain and Spine Tumor Center, Brain and Spine Institute, Cardinal Santos Medical Center. He is the Chief Radiation Safety Committee of the Cardinal Santos Medical Center, where he is also the Section Chief of the Radiation Oncology Section. He is also currently the Assistant Head of the Stereotactic Radiation Therapy Program, Radiation Oncology Section of the Cardinal Santos Medical Center. Next, we have Dr. J. Arnold Fumador, who is an active consultant of the Section of Gynecologic Oncology of the Makati Medical Center and St. Luke's Medical Center, Global City. He is a member of the International Gynecologic Cancer Society, European Society of Gynecologic Oncology, Society of Gynecologic Oncologists of the Philippines, and the Philippine Obstetrical Gynecologic Society. Lastly, we have Mr. Jason Francis Ross. He's a lymphedema nurse at the VRP Medical Center and St. Luke's Medical Center, Global City. He is the founder of the Philippine Lymphedema Network and a member of the International Lymphedema Therapist Network, close training and consulting. He is also a member of the International Society of Nurses in Cancer Care of Vancouver, Canada. He's also a member of the Philippine Nurses Association. So those are our panelists for this morning's discussion. Okay, so let's start this morning's discussion with our first case. So our first case is BC. She is a 51-year-old female who underwent modified radical resection of her left breast in 2006. She came in complaining of left upper limb swelling and limited mobility for 15 years. The details of her intraoperative lymph node dissection is unknown. She came in with swelling and heaviness in the left upper limb 6 months after surgery. So in a patient who came in with swelling after surgery, Dr. Bernardo, what are the considerations po sa ganitong kaso ng pasyente?
Okay, first, because of the length of time from the time of surgery, and it's usually progressive in nature, it might be really lymphedema, cancer-related lymphedema. It could be from the surgery itself. It could be from, we don't have the information, but did she receive any radiation or any other treatment for that, because it's been like 15 years, right? But there are also other possible things that we should always rule out in these patients when we are considering limb swelling, especially unilateral limb swelling. So we should think about other common also problems in cancer patients. Like one is deep vein thrombosis. Another one is simply cellulitis, especially if it's acute and there are signs of infection.
Doktora, sa ganun po, as a patient, is there, or as for a guide for our colleagues po, what are the tests that they need to do to rule out deep vein thrombosis or investigate if it is cellulitis?
Okay, so number one, you have to go to your doctor. Surgeons, their primary care physicians can usually tell if this is an infection, but for other things like lymphedema or DVT, you actually have to do some tests. No? Based on the clinical history, it might really be lymphedema. But the basic test that most of us will recommend vascular specialists and lymphedema specialists is to do DVT screening. DVT screening is actually compression ultrasonography. It's not a very expensive test. It's easy to do, and you can teach it at the level of, for example, in the ER, if they come in the ER. What you do is you compress the vein if it's compressible, meaning there's no clot inside it, right? For lymphedema, after you have already ruled out deep vein thrombosis of the upper extremity, which can be life-threatening aside from limb-threatening. For lymphedema, there are other tests. We have bioimpedance spectroscopy. You can do ultrasound also. In our center, in Makati Medical Center, we have a protocol we call lymphedema ultrasound. In that ultrasound, we actually do a lot of things, including check the veins for the vein thrombosis, check the arteries, the distal arteries, the radial and the ulnar if it's the arm, and also measure the skin thickness, subcutaneous tissue for edema. It will have a certain pattern when you look into the ultrasound. So this is not a direct test, but an indirect test to diagnose lymphedema.
Doctora, you mentioned this ultrasound. Is this necessary po ba to diagnose lymphedema, yung pag-ultrasound ng lymphedema protocol?
The lymphedema protocol, actually I made that protocol based on some of the protocols that I saw in my travels to Japan, where lymphedema is pretty common. They are in the cutting edge of doing the ultrasound for lymphedema, actually. So we went to Tokyo and observed. It is required to rule out the other common cancer-related diseases that can cause swelling of the arm, like DVT. But if it's necessary, no, but it's really highly suggested, recommended to do it.
Okay.
Because it's cheap, it doesn't have radiation, it's easy to perform.
So, Doctor, you mentioned kasi that lymphedema is pretty common in Japan. I'm curious, and I would like to ask the others in our panel, is how common do you see lymphedema in your area of practice? So, maybe Dr. Ali, would you like to start?
In our case, I think breast cancer-related lymphedema is relatively common. So, we see maybe around 1 or 2 out of 5 patients with breast cancer develop breast cancer-related lymphedema. So sometimes it's because the tumor is big and has spread to the axillary lymph nodes or yung lymph nodes sa kilikili, which causes blockage sa drainage, causing lymphedema. But more often than not, it's related to the treatment. So, more often we see patients developing the lymphedema months or years after the patient has undergone treatment with either surgery with axillary node dissection or with a combination of surgery, radiation, or chemotherapy. So, pero in general, it's relatively common talaga in our practice.
Oh, I see. Kayo po, Doctor.
Lymphedema in my field of practice is quite common, as Dr. Ali mentioned. It occurs in about, on average, mga 20% of all patients undergoing modified radical mastectomies. It's pretty quite common, and perhaps these incidents, pwede ba tumaas, ano? Kasi nga, may problems with under-reporting. So,
Okay. Kayo po, Dr. Carabello, in Rad Onco.
So actually, Doctora, the incidence of lymphedema is quite common. However, probably in our field, it's quite underreported, even for the other fields as well. Mainly because yung pag-catch up ho nung data might be not available in our local setting or hindi ho nare-report agad-agad. So, when you look at the literature, about 5 to 50% can develop lymphedema depending on dun sa sinabi rin ho ni Dr. Ali and Dr. Azares. So it depends on the surgical dissection, yung extent ho ng surgical dissection that was done, the patient's radiation treatment field, yung dose ho ng radiation na binibigay ho namin. So kapag nag-compound ho lahat ng mga effects na yon, tumataas ho yung up to 50% yung incidence ng lymphedema.
So, Dr. Bernardo, they mentioned po, no? Medyo common sa area
Yes.
nila. Kayo po, as a vascular medicine specialist po, I'm sure you see most of these patients po.
Yes.
And are there any patient characteristics po, or are you common amongst those who develop lymphedema?
Okay, actually, they're all correct, ano? Nasa 21% ang prevalence ng breast cancer-related lymphedema. There's a prospective study talaga over 900. This one is an international study. And patients develop mga 21%. Ano? And they found out that axillary lymph node dissection is a risk factor. Chemotherapy also, especially taxane-based chemotherapy, was a significant factor. Regional node irradiation, I think Doctor will expound on that later. And also, being obese, yung body mass index na more than 30. No? And also, another one is yung where they are located. Pag nasa may far-flung area sila, so hindi sila makita agad ng doktor, it's hard to access a healthcare institution, you know. So, yun, rurality is also a risk factor, ano. But there are also some other factors, but not the same for each study, like development of seroma, patient characteristic factors like the type of cancer, breast cancer, if it's positive for this receptor or not. So those are the things that can predispose a patient to lymphedema.
Oh, okay, Doktora. Sige po. So, I'd like to go into swelling, Dr. Azares, no? Kasi syempre, pag maga na-associate after surgery, may konting swelling po, di ba? Syempre, because medyo maraming nakarinig ng lecture natin. So, lahat ba ng namamaga, post-operatively, pwedeng mag-lead na kaagad to lymphedema?
Well, as you mentioned, swelling or any form of inflammation is expected for a few weeks to a couple of months. There is no specific timeline as this differs to every person. However, if the swelling persists to a prolonged period coupled with other limiting symptoms such as number 1, tightness in the affected limb, decreased flexibility, changes in skin texture, obvious differences in the size in comparison to the other limb, then lymphedema should be considered. If this is noted, one should take note of the onset and triggers, and I would say lymphedema is usually gradual rather than sudden.
Okay. So, sir, how would you advise po patients to look at it? I mean, when would it cause concern po for them in terms of, sabi nyo, timeline is different, but on the average po, if it persists beyond this time, it requires further investigation?
Yeah, I usually advise my patients, especially those undergoing modified radical mastectomy, to take note of the ipsilateral limb, and by practice, I ask them to compare the diameters of their arms and their forearms and compare it to the contralateral side. And if they see any differences, meaning pag lumalaki na yung ipsilateral side or the same side, in a span, mga 2 months to 6 months yung binibigay ko na usual.
So, okay, sir. So, you would say, beyond 6 months and there is still swelling, you would advise them?
Yeah.
To see. Okay. Sige po. So, curious po ako, sir. Have you treated a patient who already had lymphedema prior to surgery?
Prior to surgery, so yes, I've treated quite a few already. Especially for those who are presenting with the locally advanced breast cancers, who by practice we usually treat them with neoadjuvant chemotherapy first, and having the exact indication of a fairly huge mass with a heavy axillary burden. Those are the types of patients in whom, before I operate on them, they already have a pre-existing lymphedema on the ipsilateral.
Oh, okay. So does this affect yung treatment plan po ninyo, or do you have to call our colleagues for any pre-treatment?
So before embarking on any surgical procedure, I'd rather have them first, or rather shrink their tumor first with chemotherapy.
So does the presence of lymphedema, Doctora, affect treatment plan for patients who have lymphedema?
For the med-onco side, in general, the chemotherapy plan for patients with and without lymphedema are about similar naman. So what we do usually is Rather than, usually kasi treatment-related yung lymphedema na nakikita namin. So usually what we do is just try to decrease the risk or the chance that the patient will develop lymphedema in the future. So for patients who are already post-op, what we do is we try to avoid mga IV insertions or blood extractions on the same side of the surgery. So if the patient had surgery on the right breast, we avoid procedure sa right arm. Yun lang. And then at the same time, since most of the cases we see are treatment related already, we just really have to monitor the patient closely during treatment and after treatment so that if ever there are signs that there's beginning lymphedema or may signs of swelling, we can advise the patient and then refer to any lymphedema specialist if needed.
I see. How about you, Dr. Carabello, as a rad onco po? Does the presence of lymphedema delay, for example, treatment or radiation?
So that's a good question, ho, no? In some ways, yes. In some ways, no. It can affect the treatment plan of the patient, but we don't usually delay. Para ho sa amin, we have to know first the cause of the lymphedema. Is it caused by treatment-related, meaning by effect of the surgery or chemotherapy, or another cause? Remember that lymphedema can be also caused by secondary or relapse ng tumor or nodal relapse, which can cause further lymphedema as well. So in these cases, we have to weigh the cost-benefit, the risk-benefit ratio of the patient, and kailangan namin i-assess kung we will be aggressive with the radiation treatment or we will be conservative or what, like Dr. Azares said, that we should tailor the radiation fields that we will be doing for the patient. Most of the time, our radiation fields are hindi naman ho dekahon, but we usually have our regional lymph node irradiation fields for patients who really need prophylactic radiation treatment to the axillary and regional lymph nodes. But in some cases, we have to tailor fit ho talaga depending on the presentation of the patient. Minsan ho kasi, patients already have lymphedema, and sometimes that can be debilitating for patients. No? So we have to explain to the patient as well if they will really need that regional lymph node. For example, some risk factors like extranodal extension to the axillary lymph nodes, o kaya they have entry disease. No? So yung mga cases na yun, we really have to explain to them that our radiation treatment has to be aggressive.
Okay.
May I add
Yes,
also?
Dr. Of course.
In some centers in the States, they actually promote a specific protocol for following up the patient because of the high risk nga na magka-lymphedema sila. So may protocol sila on measuring if the patient is already beginning to have lymphedema using yun ng bioimpedance or yung tape measure to get the volume. And once they see na merong change, for example, sa tape measure volume, if it's more than 10% increase, they actually start manual lymphatic drainage or compression garments. No? But for all patients, I think dapat sabihan natin sila yung mga subtle details. No? Kasi yung iba, malaki na pag nakita. Kung heavy, may fatigue na sila, it's already hard to treat. But for example, sumisikip na yung sleeves nila, yung ring nila, yung wedding ring nila, sumisikip na. No? So yung mga ganon na changes. For us na lymphedema experts, actually just touching the skin, we can feel if there's accumulation of fluid. You know? You have to compare it to the other normal arm or normal leg, but you can feel it. It's doughy. You can feel the fluid there.
So, Dr. Azares, I would like to ask, is there any way that you can decrease the chances of developing lymphedema during surgery?
In general, there are ways wherein we can try to limit the incidence of development of lymphedema. And for one, if indicated, we can perform a limited axillary lymph node dissection. We call that sentinel node biopsy for breast cancers. And limiting this dissection of the lymphatic channels without compromising the quality of the tumor control is excellent.
Doctor, just to clarify, this just minimizes the chances, right? It does not eliminate the chances of developing lymphedema.
Yes, exactly. As I've been discussing with Dr. Rojas a while ago, even for patients undergoing breast-conserving therapy with sentinel node dissection, they still develop up to about 8% risk of lymphedema on the same side of the arm.
Okay. So, Dr. Azaras has mentioned ways to minimize the development of lymphedema during surgery. How about you, Doctora? During chemotherapy, is there a way also to minimize?
I think since, as I mentioned earlier, yun lang talaga yung avoiding ng procedures on the same side affected. But other than that, we don't take any precautions.
I see. So, Dr. Bernardo, as a lymphedema specialist, is there anything you would like to advise patients po who are at risk, or also our colleagues? What do they need to highlight or teach the patients po to prevent developing lymphedema?
Okay, aside from being vigilant in examining their arms or their legs, they have to protect their skin, against, for example, any trauma, any insect bites. When they go to the beach or somewhere, vacation, they have to put insecticides. When they're cooking, dapat magsuot sila ng protective for that arm, no? So pag natalsikan, hindi magkakasugat. And whenever they develop any slight sign of infection, they should see a doctor. And actually, in one study, they do pill in pocket. Pill in pocket, they already have a prescription, antibiotic, and then they will take it at the earliest signs of infection so that you can protect the remaining lymphatic vessels and not progress to a more severe lymphedema. So exercise is also important. Patients should be counseled on what exercise to do, and also keeping their weight at ideal for their age and for their height. Okay, so these things are proactive for the patients, and they should be doing it even if they do not have yet the lymphedema, because we try to prevent it, because as studies have shown, the quality of life declines when you develop lymphedema.
Thank you, Doctora. Okay, so that has been a very interesting discussion. We've learned a lot about breast cancer-related lymphedema. So we will proceed now to our second case. So for our second case, we have OC, a 61-year-old female who was previously diagnosed with cervical cancer. She underwent radical hysterectomy with lymphadenectomy and chemotherapy. She was also subjected to radiotherapy. She was lost to follow-up, and after 1 year, she came back with heaviness. So, Dr. Bernardo, what do you think about this case?
Okay, this patient is high risk. All gynecologic cancer actually promotes possibility of having lymphedema. So they're all high risk to both lymphedema and deep vein thrombosis actually. So in this particular patient, very near, like within a year of surgery siya, I want to know first kung meron siyang blood clot. So I would request DVT screening, ultrasound, or compression ultrasonography to make sure the patient has no deep vein thrombosis, because cancer-related thrombosis is quite common. It's about 5% in general, but higher in some types of cancer like gynecologic cancer. It could be as high as 7%, pancreatic cancer. So there are certain cancers, and multiple myeloma. So these types of cancer have even higher, but in general, it's around 4.5 to 5% risk of developing deep vein thrombosis. Okay, so that's very important.
Okay. So, how about you, Dr. Famador, in your area of specialty, sir, in gynecologic oncology? Is lower limb lymphedema very common?
Edema in general would be very common. No? So actually, with regards to the previous case, if noted that she was lost to follow-up, she comes back with severe edema on one leg, the immediate thing I will be worried about is recurrence. So yun ang one thing I would like to rule out. Of course, in my mind, she went all to the risk factors for developing lymphedema. And from the picture, para talaga siyang lymphedema. Of course, we will refer to vascular medicine to rule out. But I will initially try to rule out a recurrence. Baka may lymph node na lumalaki doon, na nagbabara na sa veins, or so pag wala na yun, then we have to work out for deep vein thrombosis, and of course, malamang lymphedema.
So, sir, you said lower limb edema is common, sir, in gynecologic. So, immediately post-op, sir, patients present with...
Some, yeah, immediately post-op, which can be expected in immediate post-op normal edema from surgery. But you can also see patients even pre-treatment. Meron na silang edema because of the nature of the, you're dealing with pelvic masses either from the cervix, ovarian, or uterine, can already be compressing on the veins, and then you will see them with edema either bilateral or unilateral.
So this is prior to surgery already?
Yeah, you will see patients, then of course you'll be worried about if you're going to do surgery on them, you want to rule out if there's already a pre-existing thrombosis. So those are things you think about right away. Aside from there's just the venous insufficiency due to decompression.
Oh, yes. How about you, Dr. Carabeo? In managing gynecologic cancers po, is lymphedema common in the lower extremity?
So I have to agree rin ho with Dr. Famador, no? If we do see patients na meron hong lower extremity lymphedema, we really have to investigate if it's really recurrence, no? Kasi most of the cases that we see involve recurrent diseases, especially in the regional lymph nodes. Now, for example, in our investigation, wala ho talagang recurrence, no? Yung next thing na as radiation oncologists we have to determine is ano ho ba yung radiation na na-receive ng patient. So, for example, cervical cancer patients, we do external beam radiation plus intracavitary brachytherapy. So, we have to determine kung both po ba na-receive ng patient na yon, ano po yung extent ng radiation field. For patients who have lower vaginal involvement, sometimes natatamaan ho namin yung inguinal lymph nodes. So that would also put increased risk for lower extremity lymphedema for this patient. And then finally, the dose of the radiation will always take into account. Mas mataas ho yung dose na receive ng mga pelvic regions or pelvic lymph node regions, mas mataas rin ho yung chances for lymphedema. Now, some factors that can also apply to the previous case is yung, for example, preoperative na status ng patient if they are obese, no? That also poses additional risk for patients to develop lymphedema.
Sir, Dr. Famador, if a patient does have lymphedema when you see them for the first time, would this affect your surgical plan for them, if ever?
Yes.
So would you delay surgeries?
It depends on what the cause of the edema is. No? So if it is because of the mass compression, then it provides more urgency to be able to alleviate that either surgically or through other treatment modalities. If it's because of, let's say, thrombosis, then you become hesitant to going right ahead with doing surgery, to have that treated first, or to look for alternative treatment modalities that can already address the malignancy while your vascular medicine colleague is treating the thrombosis. But I'd like to go back to your original question, how often do you see actual lymphedema? In my practice, actually konti lang, no? Mabibilang po yung talagang lymphedema, and these are, I suppose, a treatment-related lymphedema. Secondary to maybe to the lymph node dissection, maybe a few. But in the literature kasi, magulo, marami. That's a wide range. I think it's not well studied as much as for breast cancer. But in our field, in gynecologic oncology, I noticed for the past few years, an awareness of this problem is increasing, and they've been trying to come up with ways to try to prevent lymphedema, coming from the experience of the surgeons with regards to the treatment of breast cancer. So, so I've been seeing them, and but most of pero edema in general, lower extremity, you see that a lot.
I see, sir. So it's like similar po to the breast cancer patients and them do similar po to breast cancer treatment when then the surgeons do the sentinel node biopsies.
Yes, actually, sentinel node biopsy came from breast treatment surgery. We're beginning. It's actually in Europe and the United States. They're promoting, starting to promote the use of sentinel node mapping and biopsy. It's just that it's not yet that well developed in terms of protocols, but we're starting to also start doing that in our country. So maraming involved. You have to get patho involved, and there's the equipment involved. But I noticed that we're going in that direction. Yeah.
So aside from that, sir, is there any other way to minimize development of lymphedema in patients with gynecologic cancers?
It's hard. Part of the treatment surgically would really be formal lymph node dissection. Usually, I noticed that they say that basically the more nodes you get, the higher the risk of developing leakage. We know that, no? So, but at the same time, there's a standard to the number of nodes you should be able to get. So parang if it's too little, they say they did not do an adequate surgery on the patient. So there's that push to say that I did a lymph node dissection, I have to have this much nodes. So it's trying to find a balance. We haven't really found out ways intraoperatively maybe to prevent, but in some papers they would say that there are certain areas that, for example, in the iliac nodes, to minimize dissecting the circumflex iliac area, but there's no evidence if it's really effective. I think for me, we don't have a choice but to try to do that. My reading is that what will help patients post-treatment would be to early diagnosis. So if you catch them earlier, it's easy to prevent. But if the lymphedema has progressed, then it's so hard to reverse. I think that's the takeaway that I can offer. Yeah.
If I may add
Yes,
also, actually we have local studies in lymphedema, both arms and legs, and about 50% are actually cancer-related, at least the ones that are seen in our institution in Makati Med. There's also a study done in Philippine Heart Center. Again, 50% are cancer-related lymphedema, those patients that are referred to them. No? So, and I also read that Dr. Famador said that the number of lymph nodes daw na tinanggal. Ano? But in this particular study, it's a retrospective study for the lower extremity lymphedema. They found out that the risk factors to develop lymphedema included more than 30 pelvic lymph nodes removed, and then the para-aortic lymph node dissection, and then the adjuvant na external beam radiation, and also laparoscopic surgery for one reason or another. So these are things that increases the risk of lower extremity lymphedema. In breast cancer-related lymphedema, it's around 21%. In the lower extremity, it could be as high as 24%. And usually, they're more severe because dependent siya, yung legs natin, dependent. And of course, the patient, there's also a high risk for chronic venous insufficiency to begin with. So these are harder to treat actually when we see them. They are the one that can have bukod sa DVT, lymphedema, all these things because of the compression nga. So they can actually have the phlegmasia if they have extensive DVT too, these patients.
Siguro isa pang ma-add ko with regards to my field, no? More often than not, treatment for my field of cancer should be a combination of surgery and or radiation or chemotherapy, no? So parang ang nagiging principle din sa amin recently to guide us also is to limit the number of radical treatments. So for example, cervical cancer, naoperahan mo na, binuksan mo. And in your intraoperative findings, alam mo na that she will require radiation post-op. Maybe the size or maybe. Then, you're guided not to anymore do the radical lymph node dissection. Kasi alam mo, unless there's bulky nodes, then you would just try to concentrate on that bulky node and remove it. Hindi na yung formal dissection ng buong iliac veins and arteries. No? So that's because alam mo na combining radical surgery on the nodes and the radiation will increase the risk of lymphedema. And you know naman that she will require radiation. So just do the radical hysterectomy and not to touch anymore the lymph nodes and post-op to plan out radiation. So only if you know. Ang problema kasi early stages, let's say you're dealing with a small, potentially early stage, part of the treatment surgically would be really a formal lymph node dissection to actually provide evidence that you see is early stage. So kung negative na yung nodes, you have to submit them to show that the nodes are really negative so that you know that she's early stage. Or to find out if there are really micrometastasis to the node so that you can plan adjuvant treatment after. So yun yung dilemma doon. Pero from the start, alam mo na, kailangan ng radiation to. We try not to touch the lymph nodes anymore.
Oh, I see. Dr. Carabello, anything to add? As he mentioned, Dr. Famador mentioned that treatment with gynecologic cancers usually require radiation. Are there ways that we can minimize development of lymphedema?
Actually, maganda ho yung mga points na sinabi ni Dr. Bernardo at Dr. Famador, no, na we really have to act as a team, no, in decision making in these patients. Na-mention ho ni Doctor that for some patients, sometimes hindi na sila nagli-lymph node dissection if alam nilang kailangan ng radiation. Dapat yung mga radiation oncologists, ganun rin minsan when they talk with the team, na this patient ba will need external beam radiation pa or they can do with just intracavitary brachytherapy. Kasi we know that the evidence of lymphedema would be less for intracavitary brachytherapy. Basta, hindi ho na-compromise yung standard of care. Yun ho yung importante. And yung sa na-mention ho ni Dr. Bernardo, the more that, for example, locally advanced disease, when we do para-aortic radiation therapy to the para-aortic lymph nodes, tapos may inguinal lymph node radiation pa, talagang yung extent ho ng lymphedema will be, or incidence of lymphedema will be increased in risk. No? So, the decision-making of the radiation oncologist with the help of the multidisciplinary team will really take into account in decreasing the chances of lymphedema for these patients.
So before we end the discussion on a patient with lower limb lymphedema, I would like to ask Dr. Bernardo if she has any tips or suggestions for patients who are at risk for developing lymphedema or have lymphedema of the lower extremity.
Okay, in general, it's similar to preventing lymphedema dun sa mga post-mastectomy patients. But the thing is, you have to be vigilant in the slightest signs of lymphedema of the leg. Like for example, yung pants niya sumisikip on one leg versus the other. Pero it could also be both, no? Pwede rin kasi both legs are affected. Especially if they removed a lot of lymph nodes and the patient had radiation, no? Yung mga pants nila sumisikip, no? Aside from that, may heaviness, may feeling of fatigue. Yan mga nararamdaman nila. Aside from the changes na nararamdaman nila when they feel the skin, in general, you also have to take care of the skin integrity. Avoid any insect bites because cellulitis or even inflammation, any inflammation can add to the burden of lymphedema. It can destroy the remaining normal lymph structure, no? So you have to avoid that. Being physically active is advised sa patient. So exercise, being in the ideal body weight, or even losing weight, is effective. And those are the things, the general things that you need to do as a patient when you have this kind of disease or preventive. There are also compression garments that we can provide the patient. The same garments that we provide, for example, chronic venous insufficiency, which is fairly common, can also help the patients with lymphedema. Pero dun sa mga severe na talaga, they have to really see a lymphedema specialist because they might need to undergo a special manual lymphatic drainage, or this is a special scientific massage to drain the fluid elsewhere para ma-prevent natin yung mga skin changes like fibrosis, nagsusugat, papillomatosis. So it can really bring down their confidence kasi if it becomes really chronic na affected na not only the quality of life, they feel fatigue, pati yung kanilang confidence, so ang laki na, tas may skin changes na, so those things we want to prevent.
So, thank you, Dr. Bernardo. So, that has been a very interesting discussion. I would like to thank our panelists for joining us in the discussion of a patient with lower limb lymphedema. To learn more po about how we treat or manage patients with lymphedema, we're joined by Mr. Jason Rojas. So, Mr. Rojas, thanks for joining us again.
Thank you very much for inviting me here.
Okay, so I give the floor to you to discuss on treatment of lymphedema.
So the treatment for lymphedema is quite established worldwide. We are very fortunate that in the Philippines, we also employ a technique that we call complete decongestive therapy, which is still currently the gold standard of treatment wherever you go in the world. So you have lymphedema, usually they will start with complete decongestive therapy. So complete decongestive therapy has several parts. So foremost among them will be exercise, skincare, and then you have to do compression, bandaging, and then gradually will progress to compression garments. And then I would say the key element of lymphedema therapy is a physiotherapeutic approach we call manual lymphatic drainage. It sounds very technical, but almost all patients enjoy this procedure because it's quite similar to a massage. So the patient is lying down, the patient is very comfortable, and then we perform a series of strokes that will gradually enable the lymphatic fluid or the protein that's left in the extremity to drain using the normal pathways of the body. So if done correctly, this is a very soothing and yet effective technique to treat lymphedema.
Oh, okay. So, Sir Jason, yung process na yon, how long does a session of lymphedema therapy take?
It depends per institution, but generally, usually we budget an hour. So within that hour, you already do a few steps. Number one, you do your history taking. You, of course, measure the limb, which is something that cannot be emphasized enough. So you'd like to have a good baseline data, and you'd also like to be able to track the progress of the patient as you go through the sessions. Apart from that, you also have about 30 to 40 minutes of lymphatic massage, the manual lymphatic drainage, and then you have about 15 to 20 minutes of compression bandaging. So I would say 1 hour is a good baseline.
So after an hour, how many sessions would you say you would recommend to a patient and tell them, oh, after these number of sessions, your limb will have a size that is similar to the non-affected limb?
Yeah, that's a very common question we get from a lot of patients. So normally, a lot of patients are quite hesitant because they're afraid that the treatment might be long drawn, that they might need a couple of sessions. But we're very happy to report, and this is actually documented in a study that we did from examining our patients from 2016 to 2018. So we found out that it only takes between 6 to 7 sessions of lymphatic therapy for us to be able to achieve a very significant decrease in the size. Also, we're looking at a significant improvement in range of motion and generally in the well-being of the patient.
Just to clarify, when you say 6 to 7 sessions, are we talking about daily therapy, or can like the patient come on a weekly basis and still expect the same improvement?
Yep, that's another very interesting question. It would also depend on the institution, but for us, we do the treatment 2 times a week, and yet despite the 2 times a week session, we have very, very good clinical outcomes. So a lot of patients are very happy with the reduction in size and improvement in quality of life.
Oh, that's very encouraging. No? So my other question is, for patients who undergo treatment, are there any problems you've encountered?
I would say a big problem that's being faced by the patients would be in terms of logistics. Sadly, in the Philippines, we have only a few centers with lymphedema therapists. So it's common experience for us to get patients visiting from the provinces. Sometimes they'd have to travel by land for about 3-4 hours just to get to a center with a lymphedema department or a lymphedema specialist. So it would really be beneficial, especially for our dear patients, if our tribe of lymphedema specialists increase.
Okay. So going back to the therapy session, so like after the 6 or 7 sessions of twice a week therapy, so at this point, would the patients be already considered cured? Would not be controlled, or or do we already transition into the maintenance phase?
Yes. Actually, what we try to do during the treatment is we divide it into 2 phases. We divide it into the intensive phase, which translates to the twice a week sessions for roughly about 2 to 3 weeks. And the longer phase is the maintenance phase, because of course lymphedema is potentially a lifelong condition, and we would like the patients to maintain the size improvement. We would like them to maintain their level of physical activity in the long term. So when we divide the treatment into 2 sessions, so it's important also to understand that during the intensive phase, generally, we start with compression bandages. So there are a lot of benefits to using compression bandages versus the stockings. So you'd especially find that the containment and the level of pressure of a short stretch bandage will be superior to compression stockings. However, going to the maintenance phase, when the patient is more or less reduced in size very significantly, we start to factor in patient comfort and convenience, which is why we recommend using compression garments, or the new generation of compression garments will be the adjustable wraps. Yes, so this is like combining the stability and the compressive ability of the short stretch bandage with the ease of use of compression garments. So this really shows that our field for lymphedema is ever evolving, and definitely we are looking for a lot of ways to make it more convenient and comfortable for our patients.
You talked about the garments and then the wraps. Are these materials readily available in our country?
We are lucky that we have an increasing number of suppliers providing short stretch bandages and compression wraps and also compression stockings. So yes, you would be able to buy these in the Philippines, but I would like to stress it's very, very important that you still consult with your medical practitioners, because not all stockings and not all bandages are the same. You know, Doctor, actually in Europe, we have a separate club. We call it the International Compression Club, that really deals with the study of the compression bandages and compression stockings. So definitely not all these stockings are the same.
Oh, not all stockings are created equal. Okay. So after treatment, let's say your patient's already in the maintenance phase, does it ever come to a point that they do have a flare, or there is a sudden increase in the size of their limbs again?
Yes, absolutely. There are some patients who are very well managed, let's say for a year or 5 years into their treatment. But over time, there will be some cases where the arm or the leg suddenly gets a little bigger. If that happens, we make sure to introduce the concept of self-care for our patients because, as I mentioned earlier, our goal is really long-term management. The patients should be able to manage lymphedema by themselves in the long term. But for example, if these patients have an experience of flare or a sudden increase in size, then the patient will simply do the self-massage and then they'll shift back to bandaging. Then usually the swelling would resolve after a while.
Oh, I see. So after your several years of practice in lymphedema care, what have you noticed are the common triggers for these flares or sudden increase in lymph size?
Well, unfortunately, a lot of these flares can be attributed to the fact that some of these patients are already happy with their size. They're thinking, oh, my leg is already small, my arm is already small. Maybe I will stop wearing my stockings for a few days. And then that stoppage of wearing the stockings will extend to a week and then a month. So eventually, because of the absence of compression, that's where you experience the flare. So I would say it can really be traced to compliance of the patient.
So I hope everyone has learned a lot about how to manage lymphedema. We see that it is not just a one-time fix, but it requires a self-care and maintenance phase in which the patient actively takes part in managing their lymphedema.
In summary, lymphedema can affect both patients with and without cancer. The development of lymphedema is affected by patient factors, disease factors, and treatment factors. The risk of developing lymphedema may be minimized through modification of surgical and radiation techniques, as well as self-care. But it's important to note this risk cannot be totally eliminated. Treatment of lymphedema involves the two phases of decongestion and maintenance. These involve an interplay of manual lymphatic drainage, multi-layer bandaging, skin care, compression garments, and exercise. Since it is a lifelong condition, patient compliance to compression and commitment to self-care is essential.
World Lymphedema Day.